Today, we'll be reviewing the case of a 42-year-old woman who presents with acute febrile polyarthralgia following recent international travel. We'll walk through her history, exam findings, workup, final diagnosis, and management. The patient is being evaluated in the outpatient family medicine clinic. When asked for her main concern, she reports severe joint pain and fever for the past 4 days. She also mentions a rash and profound fatigue. Her symptoms began 2 days ago after returning from a trip to Jamaica, where she experienced multiple mosquito bites. She describes high fevers up to 102.7 degrees Fahrenheit, a diffuse rash, and intense symmetric joint pain that makes walking difficult. Over-the-counter medications have provided little relief. She denies neck stiffness, vomiting, diarrhea, or respiratory symptoms. She has no significant past medical history aside from seasonal allergies. She takes no medications and has no known drug allergies. She doesn't smoke or drink. Importantly, she recently traveled to the Caribbean, a key epidemiologic clue. Her review of symptoms is notable for fever, chills, diffuse joint pain, myalgias, rash, and fatigue. She denies any chest pain, shortness of breath, GI symptoms, or urinary issues. On physical exam, her vital signs show fever and mild tachycardia. She has a diffuse maculopapular rash on the trunk and extremities. Her joint exam reveals symmetric tenderness in the wrists, MCP joints, knees, and ankles, with mild swelling, but no large effusions. Her neurologic exam is unremarkable. From what we have so far, let's develop a differential diagnosis, which includes chikungunya, dengue, Zika, parvovirus, early autoimmune disease, or other arboreal or post-viral arthritides. Travel history, rash characteristic, and the severity of the joint pain help narrow our differential. With that in mind, we ordered a CBC, a CMP, inflammatory markers, and autoimmune screening. The CBC revealed a mild leukopenia. ESR and CRP are elevated. The rheumatoid factor and the CCP were negative. Infectious testing included dengue, Zika, and chikungunya PCR. Dengue and Zika were negative, but chikungunya PCR returned positive, confirming the diagnosis. Our assessment is acute chikungunya virus infection. The diagnosis is supported by the classic triad of high fever, a rash, and severe symmetric polyarthralgia, in combination with recent travel to an endemic region and a positive PCR testing. The management is simple, it's supportive. There is no antiviral therapy. We recommend that NSAIDs for the pain, acetaminophen as needed, hydration, and some rest. We also counseled her that joint symptoms may persist for weeks to months. She should avoid mosquito exposure for approximately 10 days to prevent further transmission. Follow-up was arranged in 1 week to reassess her symptoms. She was instructed to return sooner if she developed focal joint swelling, worsening fever, neurologic symptoms, or inability to maintain hydration. Here are the key takeaways I want you to have. Chikungunya presents with a fever, a rash, and severe polyarthralgia. The pain is often debilitating and symmetric. PCR is the diagnosis test of choice early on in the disease. There are no antivirals, and treatment is symptomatic. Chronic arthritis can occur in some patients. Something I want you to think about. How is it that you distinguish chikungunya from dengue or Zika? What patterns of joint involvement help point toward the diagnosis? What are the long-term sequelae of chikungunya? And when should we consider alternative diagnosis or specialist referral? All right, let's do a question and break it down together. So the first thing I always do is I read the very last sentence of the question. This tells me exactly what the author is asking. In this case, the question is asking for the most appropriate treatment or the most appropriate management plan. Before we can choose a treatment, we need to know what exactly the condition is that we're treating. So then I go up to the question stem and I quickly skim it. All right, so a 42-year-old in a clinic 4 days, high fever, a rash, symmetric joint pain, blah, blah, blah. She recently returned from a trip to Jamaica. So when you see a geographical location, especially an international region, that should immediately catch your attention. It's almost always a clue. All right, so I keep reading, blah, 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 where she experienced numerous mosquito bites. So another big clue here is the mention of the mosquito bites. Anytime mosquitoes appear in a question, you should pause and think, what are my vector-borne infections? So let's recall. Which vector-borne diseases are transmitted by mosquitoes? So I can think of three: Zika virus, chikungunya, and dengue fever. Now there are other vector-borne diseases like Rocky Mountain spotted fever or Lyme, but the vector is not a mosquito. The other three, and the other nice thing about these three, is that they are found in the Caribbean, which includes Jamaica, and all three can present with a fever, a rash, and joint-related symptoms. Although dengue tends to be more of a muscle pain than a true arthralgia. Now to the treatments. So what is the treatment for Zika? It's supportive. What is the treatment for dengue? It's supportive. Although something to remember for dengue is that you avoid NSAIDs initially. And what is the treatment for chikungunya? It's also supportive. So the only answer choice that aligns with supportive care is answer choice C, making it the correct choice. So let me give you a final warning here. Be cautious with answer choice A, doxycycline. It is a tempting distractor because many vector-borne diseases like Rocky Mountain spotted fever and Lyme disease are treated with doxycycline, but none of those are described in the STEM. Always anchor your answer to the clinical picture provided, not what sounds right. And the authors know this, and that's how they try to trick you.